Hi everybody, my name is Marchelle Yatsko and I'm going to be talking about updates in ovarian cancer management. I am a physician assistant at MD Anderson. I work in gynecology oncology and I've been there for the past 6 years. Prior to that, so I worked in OBGYN for 2 years and I obtained my physician assistant master's at Chatham University, which is in Pittsburgh, Pennsylvania. And I'm also a student at the University of Houston Clear Lake, working on my Master's of Healthcare Administration. I have no financial relationships to disclose, and I have no affiliations to disclose, no sponsorships awarded to me. The objectives are going to focus on high-grade serous ovarian epithelial carcinoma, so the epidemiology of that, the treatment, including surgery, chemotherapy, and PARP inhibitors. Also a touch on genetic and molecular testing updates. Ovarian cancer. So why do we care about it? The highest mortality of all gynecological malignancies, the 5th most common cause of death of women in the United States, the 2nd most common gynecological malignancy after endometrial cancer. That's in the industrialized world. In developing countries, the 1st most common is cervical cancer. Of those diagnosed with a later stage, so stage 3 or stage 4, about 70% will have a recurrence of their disease within the first 5 years. Approximately 22,000 women per year are diagnosed in the United States, and of these, approximately 14,000 will pass away. Although there have been many significant advances in the treatment of epithelial ovarian cancer, the past several decades, recurrent ovarian cancer remains almost uniformly fatal. So risk factors. Increased in number of ovulatory cycles. So repeated ovulation results in minor trauma to the ovarian epithelium, which can then turn malignant transformation. So that can also include infertility, nulliparity, age, so greater than 50 years old, a late menopause, exposure to gonadotropins. Genetics play a role. So BRCA1 and BRCA2. So with BRCA1, a lifetime risk of 35 to 46% chance of ovarian cancer, and BRCA2, a 13 to 23% lifetime risk. Additional risk genes that have been identified are the BRIP1, RAD51C, RAD51D, and Lynch syndrome. And although this talk is not about high risk, risk-reducing surgeries, those kind of would be something to fall back on genetics that would qualify for a risk-reducing Salping oophorectomy. Obesity, family history, including Ashkenazi Jewish background, and a history of breast, uterine, or colorectal cancer. Okay, so the presentation. So non-specific symptoms until late progression of disease, palpable mass or ovarian mass, so that could be on abdominal exam or during bimanual exam. Ascites, so fluid in the belly, abdominal fullness, abdominal or back pain. Early satiety, meaning you're getting, patients say they're getting fuller quicker. Bowel or bladder changes, because if the mass is pushing on the bowel or bladder. Irregular menstrual cycles or postmenopausal bleeding. Diagnosis. So ovarian cancer is diagnosed pathologically through surgical intervention. If the patient is not a surgical candidate, and we're going to go through all of that, then an interventional radiology biopsy. So obtaining the ascites fluid, if getting a biopsy of a mental mass. Outcomes are best when women with gynecological cancers are treated by a gynecologist oncologist. So initially, following up with a gynecologist oncologist, having a pelvic exam, tumor markers, so CA125, and then also may include inhibin A and inhibin B, depending on the histology for high-grade serous epithelial ovarian cancer, CA125, typically the tumor marker that's used. And it is sensitive, but not specific to ovarian cancer. And CEA may be done if there's a mass in the pelvis and there's any suspicion of, is it coming from the colon or is it coming from the ovary? Assessing for metastatic disease, so doing a CT of the chest, abdomen, and pelvis is standard for assessing for metastatic disease. Histological confirmation, and then laparoscopic evaluation. And those may be done in the same order. So you may go in for surgery to find the histological confirmation. So this next slide talks about the FIGO staging. I want to go over stage 3C is the most common stage of diagnosis, and that is macroscopic peritoneal metastases beyond the pelvis, more than 2 centimeters in greatest dimension, with or without metastases to retroperitoneal lymph nodes. Okay. So primary epithelial ovarian cancer is still treated with a combination of surgery and systemic therapy. More complex surgical procedures and novel therapeutics have emerged as standard of care. So there's surgery, chemotherapy, hormonal, and PARP inhibitors. I want to go over this slide for clinical trials as a reference for yourself. So encouraging patients to participate in clinical trials during aspects of their diagnosis and treatment. And this is the website here. Okay, so for a surgical candidate, so is somebody a surgical candidate? The volume of residual disease after debulking surgery is still the strongest prognostic factor for progression-free survival and overall survival. Primary debulking is generally preferred, but neoadjuvant chemotherapy followed by an interval debulking surgery is an alternative for certain patients. And so those patients would include patients that are older, women with larger disease burden, those with multiple comorbidities. Regardless of the timing of the procedure, maximum debulking effort remains the standard of care. So an example of 2 different patients. So if a patient has a pelvic mass, it looks like it's contained into the pelvis, they do not have liver metastases, that would be a patient that, or lung disease, that would be a patient that would, and they are healthy for surgery, so they haven't any reason, these are just examples. Stroke, any cardiovascular issues, they're cleared from anesthesia standpoint. And those patients would have an upfront interval or upfront surgery, tumor debulking. Patients that have a larger amount of disease or maybe at risk may then get chemotherapy first, and then they assessed for if they would become a surgical candidate. The bottom here, and I'm going to touch on this another slide, the key thing is the optimal tumor debulking. The definition of that is 1 centimeter of disease or less that you can see with your eye. Okay, and that is really important for a prognostic factor. Okay, so surgeries, what the operation generally includes a hysterectomy, so taking out the uterus, bilateral salping oophorectomy, so the tubes and ovaries, the omentum, which is the fatty drape layer. And why that is because when we're in utero, the cell lineage kind of shares the same as in your abdomen. So ovarian cancer then metastasizes typically to the omentum. And resection of any other gross visible disease. Surgery of advanced disease often includes a combination of pelvic and abdominal peritonectomy, bowel resection, splenectomy, and diaphragmatic stripping. Okay, the mucinous tumor, the appendix will come out. And if you may ask, how do you know a lot of these patients have a frozen section done, especially if it's an upfront surgery. They will have a frozen section done. Again, optimal tumor reduction, diameter of the largest residual implant less than 1 centimeter, and suboptimal tumor is greater than 1 centimeter. I also want to make a note that pelvic washings are also important to have done. Okay, so for genetic testing, so germline and somatic, and then HRD. Homologous recombinant repair pathway deficiency, HRD, is involved in tumor genesis and progression of high-grade serous carcinoma, as well as in sensitivity to the platinum chemotherapy drugs. If somebody's tumor is positive for HRD, that means that certain treatments are more likely to be effective. And one of those treatments is called a PARP inhibitor. So polyaderopose polymerase is a type of enzyme involved in many functions of the cell, including repair of DNA damage. Okay. The recent creation of treatments and categories based on genetic changes reinforces the recommendation that all women with epithelial ovarian cancer have germline genetic testing, and new biomarker-driven drug approvals indicate that women may benefit from somatic molecular testing as well. It's also done for, so as I discussed, the treatment of the cancer, but also risks of other cancer. So we talk about breast cancer. So they would need to have high risk screening for other cancers like breast or colon. Okay. Tumor molecular analysis, next generation sequencing for BRCA1 and 2 mutations, other somatic mutations, and tumor mutation burden. Additional testing, these are particularly for endometrioid carcinomas, immunohistochemistry for DNA mismatch repair genes. So those are typically the Lynch syndrome genes, which are MLH1, MSH2, MSH6, and PMS2, and then also assessing for microsatellite instability. Okay, so the next thing, so chemotherapy. So it can be given either IV or IP, intraperitoneal. It's being, for more than 2 decades, the standard chemotherapy of primary ovarian cancer has included a combination approach using carboplatin and paclitaxel. They will be monitored through a CBC with differentials, a complete metabolic panel, and magnesium level. This doesn't mean the only thing that can be monitored, but it's standard of care. And then also scalp pulling. It's becoming popular because of the Taxol's hair loss. Okay, so primary treatment of chemotherapy, the 2 bread and butter chemotherapies are carboplatin and paclitaxel. So carboplatin, the standard dose is an AUC of 6, and Taxol is 175 milligrams per meter squared. It can be given neoadjuvantly or adjuvantly. It is administered once every 3 weeks. GOG 252 show no advantages in progression-free survival or overall survival was observed in optimally resected patients with stage 3 disease, even given either IP chemotherapy regimens compared with IV only after a median follow-up of 85 months. So that shows that IP has higher toxicities. It's more complicated to give. You have to have staffing that is trained to give it. And so it has more, the IP has more toxicities than the IP to give. Okay, so again, this is just kind of the recap. It can be given before surgery, for 3 cycles, assessing with a CT chest, abdomen, and pelvis, seeing if the patient is now a candidate for surgery, depending on their disease level, or if they had comorbidities managed better. And then sometimes adding Avastin Okay, a minimum of 6 cycles of treatment is recommended, including at least 3 of these cycles have adjuvant after interval debulking surgery. So if somebody does have a debulking surgery up front, they would have all 6 cycles to follow. Patients with stable disease who are tolerating therapy may continue past the 6 cycles. And the way Avastin is given, and we'll go through that in a couple of the next slides. It's for cycle 1, day 1, it will be given with carboplatin and Taxol, and then it would be given cycle 1, day 15. So it would be given on day 15. Adverse effects. So bone marrow suppression, so neutropenia, anemia, thrombocytopenia. So that's why we're watching those labs each time before we administer the chemotherapy. GI toxicity, so nausea and vomiting. So we give Zofran with on top of other pre-meds before the chemotherapy. We also give anti-emecs for 3 days after. Hepatic impairment, 3 days after, and then as needed. Hypersensitivity reactions, neurotoxicity, so neuropathy, that's most common by the Taxol. Sometimes we need to lower the dose or change, sometimes if the neuropathy is too bad, to Taxotere. Fatigue, cardiovascular, including flushing, dermatological, so alopecia and skin rashes, and arthralgias. So patients will often complain if it's too bad, like long bone pain, and sometimes we need to lower that Taxol dose. Okay, Avastin, it's administered at 15 milligrams per kilogram. Consider in patients with suboptimal tumor debulking, patients with stage 4 disease, or those who have a poor response or refractory to frontline carboplatin and Taxol. The importance here is it needs withheld for 6 weeks prior to surgery. Okay. And that's because it has effects on healing. So essentially how it works on the cardiovascular system. So it works by preventing the growth of new blood vessels, okay? So it's important to monitor for high blood pressure, heart failure, hemorrhage, and educate patients at an increased risk that they could be at an increased risk of a DVT or pulmonary embolism. And this is not for somebody that has a tumor or bowel disease because of the risk of GI perforation or fistula. That is because the Avastin works kind of too well, and it could make a hole and cause a GI perforation. Osteonecrosis of the jaw. So some people have a dental visit or a clearance before this. Proteinuria and nephrotic syndrome. So it's monitored so many cycles with a urine analysis, and wound healing complications like I discussed. So I have patients, make sure you're not having your tooth extracted or some big surgery without telling the doctor you're on Avastin. Yeah. So adipose ribose polymerase inhibitors, they're for patients with platinum-sensitive relapsed ovarian cancer with a partial or complete response to platinum-based chemotherapy. Some examples are niraparib, olaparib, and rucaparib, so the ribs. They're approved for FDA for maintenance therapy. And while progression-free survival outcomes are improved with these agents, regardless of the BRCA mutation, data of overall survival outcomes are pending. So PARP monitoring and adverse effects. So pharmacological inhibitors of the enzyme polyadipose ribose polymerase. It's first-line maintenance for BRCA positive patients and or if they're HRD positive. So if there's no evidence, so an example, no evidence of disease, and a patient is positive for BRCA1, they will then start a PARP inhibitor. For example, Lynparza. It's given 300 milligrams twice a day until disease progression or unacceptable toxicities. So those patients, you're still going to be monitoring with a CBC, a CMP, and a magnesium level. In the beginning, it's going to be more frequent than if patients have been on it for a few months. Dose reduction, if the creatinine clearance is 35 to 50 milliliters. Adverse effects, hematological toxicities, neutropenia and thrombocytopenia, GI toxicities, low magnesium, fatigue. It can cause DVTs, pneumonitis. Rare but secondary malignancies can occur, MDS and ALS. And it's important to educate patients to avoid grapefruit juice, Seville oranges, and Seville oranges because of the interaction with the PARP inhibitors. Okay, I threw this slide in. So this is not for necessarily high-grade serous ovarian carcinoma. This is more towards low-grade serous or granulosa cell tumors. But I did want to say, put this in for anastrozole, letrozole, tamoxifen, leuprolide, and megase can be used for these types of histologies. And the monitoring of a CBC with differentials, and definitely a complete metabolic panel because of the liver enzymes that can raise them. So aromatase inhibitors are letrozole. Okay. Immunotherapy. This is more for endometrioid or endometrial cancer, but there is, all these buzzwords of, immunotherapy. It's more for advanced endometrial cancer. And so Keytruda is an example from microsatellite instability. So when I said the genetics part that we do genetic testing, so what would happen if something came back as MSI unstable? Then that patient would qualify for Keytruda. So follow-up and surveillance. So briefly, when a patient has no evidence of disease, and we've established that, the first year we see them every 3 months with a CA-125 or other tumor markers that may be more sensitive to their histology. For example, if it was granulosa cell tumor, you would consider inhibin A and B along with a CA-125. Year 2, once every 4 months, so that includes a pelvic exam plus tumor markers. Years 3 through 5, once every 6 months, plus tumor markers. Okay, so for recurrent, again, although there have been many significant improvements in ovarian cancer, recurrent ovarian cancer remains almost fatal. So it can be surgical if there's one spot that we need to remove. Systemic, so platinum sensitive, progression free of 6 months or longer. You can restart carboplatin and Taxol. Platinum refractory, that's progression free less than 6 months. Examples to consider: Doxil, Taxol, and Avastin. Again, that's just an example. Post-recurrent treatment for PARP inhibitors plus Avastin. Duration, so olaparib until disease progression or unacceptable toxicities, or up to 24 months. Avastin until disease progression or unacceptable toxicities, or up to 15 months. The NCCN is a great reference in their section for ovarian cancer treatments. Thank you.